Good evening, colleagues, fellows. This is the first time we are going to start these evening classes, evening E-classes, evening E-classes, interventional assessment. And there is we do a lot of interventions every day, and how these patients keep on coming to the OP. So how we are going to assess these patients in the OP room. All these things we need to know very clearly in our mind. So in the last 2 decades, there has been a real revolution in treatment of congenital heart disease, and now most of the congenital heart disease are treatable in the cath lab. And of course, definitely a few we leave them to our surgical friends. So then, in any intervention, there should be 3 parts. One is pre-intervention assessment, the intervention per se, and the post-intervention assessment. All the 3 parts are equally important and should be given equal importance as the intervention part of it also. So I'll deal the topic in 3 subsets, like pre-intervention assessment, the intervention per se, and the post-intervention assessment. To start with the pre-intervention assessment, there are a few definite golden rules. Like there should be a very rigid selection criteria. One should remember that everything and anything cannot be closed or opened in the cath lab. Vigilance level should be very high, and it is always nice to remember that it is nice to be brave in the cath lab, but do not be overconfident. That can kill everything. Being overconfident can kill your confidence for the next few ensuing cases. So we can be brave, but we should not be very sure that okay, we'll do it, come on, let's do it and finish it up. And you cannot do everything in the cath lab, so always the surgeon friends should be around, and they should be notified that some important or complex cases are being done. And if a patient cannot be treated totally in the cath lab, always the threshold for sending to the surgical team should be very low. There should not be any ego problem, especially when you are dealing with congenital heart disease in the cath lab. So a few questions like which ASDs cannot be closed in the cath lab to start with. Any participants till now? Yeah. So okay, which ASDs cannot be closed in the cath lab? You guys also can answer. There was yeah. With 4 rims, right to left shunting, division rims. Okay. Which anatomical ASDs other than this division rims, and which other ASDs cannot be closed? Yes. So sinus venosus and coronary sinus ASDs, and division rims, ostium primum, like ASDs which are associated with ostium, with as a part of endocardial cushion defect, those cannot be closed. Yeah. They are part of the sinus venosus ASD anyway, with abnormal pulmonary venous drainage. So very large ASD with inadequate rims in more than 2 aspects. See, if 2 opposite rims are absent, like the anterior rim and the posterior rim, if they are absent in the same patient, it is not very prudent to close those ASDs in the cath lab. Then sinus venosus ASDs and ostium primum ASDs also we should not try to close in the cath lab. Which VSDs cannot be closed in the lab? Any answers? Which VSDs cannot be closed in the lab? Come on. Yes. Very close to aorta. Okay. Next. Inaccessible line.
Very remote. Inlet VSD one and very
So inlet malaligned large VSDs with no rims, and apical muscular VSDs can be closed in the cath lab. Definitely can be. Apical Danya says that apical muscular VSDs, but they can be closed in the cath lab. Actually, they should be closed in the cath lab because surgically the apical muscular VSDs become very difficult for the surgeons to access. So apical muscular VSDs are the ones which should be closed in the cath lab only. And the other VSDs which should not be closed is the perimembranous ones with very deficient aortic, subaortic rims. But people do it. But there are chances and there are incidences of complete heart block So we better be careful when we are dealing with those cases. So perihumeral VSDs with no subaortic rims, Swiss cheese VSDs, probably Dhanya wanted to mean Swiss cheese VSDs when she said apical muscular VSDs, but Swiss cheese VSDs also, it can be closed probably in a hybrid approach, like putting devices in the OR theater, I mean operation theater, where you can close probably the bigger ones with surgically, and the smaller ones which are not accessible by the surgeons, they can be closed with in a hybrid technique with the device being put in the OR. Okay. So other cases to avoid in the cath lab are large PDAs with severe pulmonary hypertension in small infants less than 3 kgs. You can close this with some coils, but then again the hardwares which are available now are not the best for tackling these very small kits, but still you can close even preterm PDAs with coils which are possible at times. And PDA in a ductal dependent pulmonary systemic circulation for obvious reasons should not be closed. Okay, any intracardiac shunt or stenosis associated with any other lesion not curable by intervention in the lab. These lesions should not be managed in the cath lab. Can you give some examples of these? Any intracardiac shunt or stenosis associated with any other lesion not curable by intervention in the lab. We should not go ahead and close this. Any example? Excellent. Coarct with VSD. If you have a coarctation with the VSD, there is no point closing either the VSD or the coarct, whichever is not doable in the cath lab. Anything else? Any other example? No, you didn't understand the question. Suppose you have two lesions together, and one lesion you cannot mend it in the exactly very large VSD and PS. Yeah. And then there was another answer, aortic stenosis with VSD. So suppose you have a VSD which cannot be closed in the lab in a very small child, say 3 kilo child, and you have severe aortic stenosis. So you have to identify which lesion is important. Whether the aortic stenosis is important, and if you have very small VSD, yes, you can go ahead and close and do the balloon aortic valvuloplasty. But if you have a very large VSD and severe aortic stenosis, then that needs to be dealt surgically. You understand? So the like valvular pulmonary stenosis with large VSD, where the VSD cannot be tackled in the cath lab, it's better to send it for surgery. PDA with coarctation. You can deal with this only with a covered stent if you want. But the problem in putting covered stent in very small children is that they don't grow, and the covered stent again becomes coarctation when the child grows up. And PDA with undeviceable ASD or VSD. Suppose you have a very large ASD and a deviceable PDA. So you should not go and just close the PDA. I mean, the patient will be of no, it will be of no benefit to the patient. So the patient should go, and who has to undergo a open heart surgery anyway. So you don't try to close them in the cath lab. And of course, any lesion which is isomingularized should not be dealt with. Okay, some other cases to be avoided in the cath lab is aortic stenosis as a part of hypoplastic left heart syndrome. There is no point dilating these aortic valves because they don't give you any result. If the aortic annulus is really hypoplastic, then there is no point dilating that. And then critical pulmonary stenosis with severely hypoplastic right ventricle again are a very difficult subset to dilate in the cath lab. And if you have a newborn coarctation with good LV function, it is better to send it to the surgeons. Of course, there are a lot of centers who do primarily balloon angioplasties, but if the if the newborn neonate has good left ventricular function, there is a better prognosis if you send them for surgical correction. So going on to the second part of the talk is the intervention per se. I am not going into the details of every procedure. So intervention preferably done under general anesthesia if indicated. There should not be any hesitation to put a patient under general anesthesia because general anesthesia has become so safe these days. Transitional assessment as and when applicable, if available, should be utilized. Hemodynamic stability in the cath lab is very, very important whatever procedure we are dealing with. And this is very important, like it is really foolish not to use resources if you are lucky to have them. and there is no real heroism in underdoing things. This is very important. Suppose, I mean, if you have key facility and that is available, it is better to use them and be sure what we are doing. And there is, I mean, no real heroism. Okay, I don't need anything. Just go ahead and then later on land up in problems. So there is really no real heroism in underdoing things. So if you have the resources, please do utilize them. So post-intervention assessment, the third part of the talk. So we should ask a few questions. Why this procedure has been done, when it has been done, how long these patients need to be assessed, and what to look for in each case. So why? With the job, why post-intervention assessment is important? Job done is right or just okay? Means you are happy, but could have been happier if you have done it in a different way. That assessment is very important. You have to detect early complications. You have to decide need for future procedures like stenotic lesions. You need to tell the family that these like aortic stenosis, pulmonary stenosis, coarctation, these have very high chances of recurrence in future. So during the procedure, before the procedure, after the procedure, you really need to counsel the family about need for future procedures. Okay. So when we should do these assessments? Immediately after the procedure. During the procedure, of course, transthoracic echo, transesophageal echo, the hemodynamics, fluoro, angio, everything is being done. In the evening rounds, if there is any suspicion in the cath lab, please alert the fellow on call that there is a problem anticipated. Please have a look. Like if you have put a large AED device and then you are slightly worried, then you should alert the fellow that please have a look on the device at least twice or thrice when you are in night call. Because sometimes people have seen like devices getting embolized without any sign of it, external sign of it till the next morning when echo has been checked. So that's very important for the fellow on call to know about what's happening, what has happened in the cath lab, although that particular fellow is not posted in the cath lab. Pre-discharge, of course, there should be a routine echo, and then at 1 month, 3 months, 6 months, 1 year, and as it is indicated, and then yearly or 2 yearly thereafter. Okay, and how long? It is said indefinite, at least till the operator is alive. So it means indefinite follow-up is required for all these cases. Now, post-intervention assessment, what exactly to look for? Let us start with ASD device. ECG, sinus rhythm. These patients are sometimes prone for tachycardia and bradycardia because of sinus node dysfunction. There can be coronary compressions in large ASD devices. So this especially happens in slightly older kids or even with adults with ASD. And sometimes you might see a patient deteriorating without any reason on earth after an ASD device. So quickly you have to take them back, do a coronary angio, and make sure that the coronary compression is not there. Okay, location of the device, to look for device embolization or migration of the device. Residual shunt across the ASD, flow acceleration, obstruction in the right-sided pulmonary veins and the vena cavas, and obstruction across the AV valves. This obstruction across the AV valves is very important sometimes when the AV valve rim is very less and the device has really sat near the AV valves. And if they are impinging on the AV valves, then we should very closely monitor the AV valves for any obstruction or even distortion of the anatomy of the AV valves causing regurgitation. So those things are also very important. Cardiac erosion or perforation is the rare complication with oversized devices used in patients with deficient aortic and superior rims. Newer development of pericardial effusion after device closure. New development of pericardial effusion. This is this is one of the reasons for following these ASDs, because we have often seen a mild pericardial effusion after ASD device closure in few patients, and we really don't need to do anything for them unless the pericardial effusion is increasing. and if they are increasing, of course you need to take actions. If they are not increasing, just follow them up. And it is a rare complication. I mean, if you have put an oversized device, then we should be again more careful about what exactly we are doing. So this is the echo of a child with an ASD device. Here you can see the device in position. Okay, this is the right. You can see the arrow there with the right pointing towards the right superior, and that demonstration of that is very important because sometimes when you put a large device, the right upper pulmonary vein can be slightly in problem. Okay, here again you see this is a slightly larger device in a small child again, and you see the device is impinging on the mitral valve, although it is not causing any problem to that. So this is what happens. What happens exactly is the mitral valve is a 3D structure, and the device is touching the mitral valve probably in a particular point. So if this picture is there and there is no mitral valve obstruction or regurgitation, then you really don't need to worry about it. And again, when we say patients ASD, I mean patients with ASD who have absent aortic rim, the device starts to straddle on the aorta, and in those cases you have to be very careful about the left ventricular outflow tract, whether it is compressed or whether it is really causing any problem to the left ventricular outflow tract. These are more common with patients who have less or absent aortic rim, which is often a case. Move on to VSD device closures, muscular defects. What are the points to assess on echocardiography? Again, the same things: location of device to look for device embolization or migration, residual shunt across the VSD, valvular regurgitation, tricuspid, mitral, or aortic valve. These are more important than any ASD device closure because we usually form a arteriovenous loop for closing a VSD, and there is high chance that this arteriovenous loop, the wire, the Ductal wire or the turbo wire, can get stuck on the tricuspid valve apparatus and cause damage. When we are deploying the device from the LV side, there is a high chance that sometimes the device, the LV disc, might catch this mitral subvalvular apparatus and cause mitral regurgitation. So we need to be very careful when we are doing these procedures, keeping an eye not only on the device but also what we are doing with the rest of the adjacent structures. That is very, very important because the device can impinge on any of the adjacent structures and can cause problems. Sometimes we have seen the one of the leaflets of tricuspid valve getting attached to getting stuck by the RV disc of the VSD device. In that case, you have to retrieve the VSD again and go and form the loop again and redo the whole procedure, and thereby you can get rid of the problem. Okay, and again, perimembranous devices, the VSD device closure is again still controversial. It's a regular debate topic in all conferences whether to do this, close this or not. But if you have a decent subaortic rim, you can always go ahead and close this VSD, close these VSDs. Aortic regurgitation is again very important if there is hardly any subaortic rim, and if there is right coronary cusp prolapse or even earlier RCC prolapse, it is better to avoid these patients, and we should not go ahead and close this because this will definitely end up in aortic regurgitation. So this is just a picture of a VSD and a VSD device. Okay, well, this is not so important pictures. Okay. Next we have any participants more? Not really. Narayana is one. Yes. Yeah. Okay. So PDA coil closure, again residual ductal flow hemolysis. This is again very important because if you have like claims of residual PDA, they are very highly prone to cause hemolysis, and we really need to manage these patients. And if the hemolysis continues, we need to take these patients back to the cath lab and close them with another coil. I mean, you have to get rid of the residual shunt. Then flow acceleration or obstruction across left pulmonary artery and descending thoracic aorta. Okay, here I can ask a question: how many loops of the coils do you prefer to keep in the pulmonary artery side? And yeah, that should be the question, to avoid obstruction in the pulmonary arteries. Any answer? Yeah. It's usually one, maximum 1.5, but definitely not more than that. Definitely not more than that. And the idea behind the whole thing is that if you leave too many coils in the pulmonary artery, then there is high chance of pulmonary artery obstruction, flow acceleration, all these things can happen. So if you have a very decent sized ampulla, then it is better to major part of the coil on that side. Tricuspid regurgitation gradient to assess the pulmonary artery systolic pressure, left ventricular size and function, and again aortic regurgitation. So in a PDA device closure, again the points to assess will be the location of the device, residual ductal flow, and there is, if you are putting a very big device in a small child, then there can be flow acceleration obstruction across the left pulmonary artery, descending thoracic aorta. And again the tricuspid valve regurgitation to assess the PA pressures if you have done a device closure in a child who had significant pulmonary hypertension. So what are the hemodynamic changes expected or seen after closing very large PDAs? Anyone from Narayana? Hemodynamic changes expected after closing very large PDAs. Decreased PA pressures, LV dysfunction. Excellent. But why there is LV dysfunction if you are closing very large PDAs? What is the reason behind LV dysfunction? There is something else also happens when you close a large PDA. Yes. Any other answers from Krishna or Narayana? Okay. Why there is LV dysfunction? Okay. So what happens is, if the left ventricular size and function closure of large PDA leads to sudden decrease in a left ventricular preload, and this causes transient left ventricular dysfunction. But if you support these children with diuretics, I mean anti-failure treatment, diuretic digoxin, sometimes ACE inhibitors, and they really come out of it in 2 to 3 weeks time. Aortic regurgitation is the other one which happens when you close a large PDA. As the source of the distal runoff is suddenly occluded, the extra volume of blood starts causing aortic regurgitation. So these are the two important phenomena when you close a very large ASD, a large PDA. Sorry. So that's the picture of PDA device in situ. Here we should look at the nice smooth flow through the branch pulmonary arteries. Especially important is left pulmonary artery. And this is the example of aortic regurgitation which happened in a child in whom a large PDA was closed. Coarctation. I mean, this is another important thing post PDA device. Yeah, if you look at this image, you will see a little bit of the device is projecting into the descending aorta. But remember, the descending aorta is a 3D structure and you are seeing a 2D image. So this particular little bit of protrusion in the aorta is very unimportant and it's insignificant. And even if you have seen like children who develop 15 to 20 millimeters gradient across the descending thoracic aorta post pediatric device closure, they usually grow out of it within 6 months to 1 year's time. But this particular picture of a shadow in the descending aorta is not important at all, and it just gives you an impression that the device is slightly protruding but not obstructing the descending thoracic aorta. And if the gradient is like this, is less than even 10 or 12, you really don't need to worry. Okay, we move on to coarctation of aorta, balloon dilatation and stenting. Points to assess on the echocardiography will be like residual gradients across the coarctation segment. Flow in the left subclavian artery is very important. You should demonstrate, because sometimes when you put a stent with small diamonds, small studs, then there can be that, and you have jailed the left subclavian artery, which means the stent has covered the left subclavian artery. There is sometimes possibility that less blood flow might go into the left subclavian artery. So that has to be really looked into, and if that happens, that particular thing is noted in the cath lab itself, then you might actually cross one of the diamonds of the stent and then dilate that so that good amount of blood flow flows into the left subclavian artery. So this is a point which needs to be understood. Aneurysms can occur at the site of balloon dilatation site and should be looked for. And left ventricular hypertrophy and function again is very important, especially you have done a squat dilatation with a severe ventricular dysfunction. Then the serial follow-up of the ventricular function is very important. And Doppler of the abdominal aorta gives very good indication of the flow across the stented or dilated coarctation segment. The continuous flow in severe coarctations in the abdominal aorta, when it becomes pulsatile and comes near normal, you can understand that there is very good flow across the coarctation segment. So this is just a picture of coarctation which has been dilated. This is the post-stenotic gradient, which you can see 15, which is very much acceptable. Okay. Now, what is the standing wave? This is a femoral artery pressure minus descending aorta systolic pressure just below the coarctation. So if you have a coarctation, you measure the pressure just below, in the descending aorta, just below the coarctation, and measure the femoral artery pressure. Usually femoral artery pressure is more than aortic pressure. So the quark gradient is actually equal to ascending aorta pressure minus femoral artery pressure, plus you have to add the standing wave. This eliminates the underestimation or mismatch between the gradients. So we need to remember this. Femoral artery pressure minus descending aorta systolic pressure just below the coarctation. This particular amount of pressure should be added to the quark gradient to get the correct quark gradient. Balloon aortic valvuloplasty, residual gradients across the aortic valve. The maximum gradient can always be obtained from the right parasternal or suprasternal view, and they actually give the proper alignment with the Doppler signal. And peak and mean gradients, of course, you need to decide regarding the need for future interventions. And this is one point in follow-up of VAV about counseling of the family. What should be the balloon annular size in case of balloon aortic valvuloplasty? Any answers? What is the ratio of the balloon to the annular size in case of aortic stenosis? It's not early morning, it's evening, so I expect some more answers. Now a lot of people are there actually. Narana guys, you're all sleeping or what? No answers for the simple question. Answer should appear on the screen, isn't it? Everyone is sleeping. Krishna, what is the ratio of the balloon to the annular size when we are deciding what to do for a, when we are deciding what size of balloon to use in a case of balloon aortic valve?
They both put 80% there. Maybe just put your scale down on the right, you'll be able to see the answers.
Sorry?
From Narayana and Krishna. They both put 80% in there.
Just
the chat box handles there.
Right. Okay. That was the problem. Okay. Thank you. Okay, we'll put this chat box down. Right. Good. So the problems are the aortic regurgitation if you increase the size too much, and another very important thing about right ventricular pacing also is very important to avoid aortic regurgitation. So even if you have downsized the balloon, then also there is chance that if you are dilating the balloon with a high left ventricular ejection fraction, it might actually push the balloon in and out of the annulus and can rupture the valves, leaflets, and it can cause severe AR. So right ventricular pacing is one of the things which can help. Again, cardiac function, fractional shortening and ejection fraction, left ventricular hypertrophy. These are another two things which need to be. And as you see, this is an eccentric jet of AR which occurred after dilating a aortic valve, but this AR is definitely acceptable and can be monitored clinically. Balloon pulmonary valvuloplasty. Again, residual gradients across the pulmonary valve, parasternal and subcostal views. And these are the two views which gives you very good alignment of the Doppler signal. Amount of pulmonary regurgitation is not so important. So, what is the balloon annular size in case of BPV, and what is the reason? What is the reason? 120 to 130%. Okay. Now, what is the reason? Why do we upsize in case of BPVs, and why do we downsize in case of aortic valves? I think I'm clear with my question. Why do we upsize the balloons? We can upsize the balloons in case of BPVs, and why we definitely don't do it in case of aortic valves? No, that answer is not very clear. Can you slightly be more specific? Of what? Exactly. PR is well tolerated. That is a better way to put it. And this you probably low resistance, high capacitance, or you probably wanted to tell about the ventricular geometry. PR is well tolerated. So yes, and it is a low pressure jet, and AR is less well tolerated and it is slightly higher pressure. So PR is better lesion than aortic regurgitation. Good. Okay. So quantity and gradient of tricuspid regurgitation to assess the right ventricular pressures, RV function, RV hypertrophy. Infundibulal obstruction, significant infundibulal obstruction is often seen in older children with severe pulmonary stenosis, and you can land up in something called suicidal right ventricle. Can I ask you what is suicidal right ventricle? What is a suicidal RV? In which age group does the suicidal RV happen? In which age group does this happen is the first question. Second is what it is exactly. I mean, why does this happen? Okay, so what? Narayana replies that coronary supply depends on RV pumping. No, that's not the thing. No, that's not really the answer. Suicidal RV is something different. Anyone else? Krishna? No, I'm not. No, I'm not talking about pulmonary atresia intact IVS situation. I'm just talking about pulmonary stenosis, where there is definitely RVOT flow. So Krishna says pulmonary atresia opened up, results in coronary stent, but I'm not talking about that subset. This is intact IVS, but severe critical pulmonary stenosis. Any other guess? You guys, any other guess? Yes. Yeah. Yes. Yes. So what exactly happens in this happens in slightly older age group of children? That was the first question, which very muscle bound RV. Narayana replies very muscle bound RV, which is right. So what happens is when you irritate the infundibulum by dilating the valve, because this usually in slightly older children you use very long, slightly longer balloons to catch the valve properly. So when you get these longer balloons across the valve, so part of the balloon will be across the infundibulum as well. So they will try to dilate the infundibulum, which the balloon cannot do. And in the bargain, there will be severe infundibular spasm following the balloon dilatation, because you are irritating spasmodic structure. So that's what happens. So it happens very rarely, but if it happens, it's a very deadly thing, and you really need to manage the situation just like the way you manage spells, cyanotic spells. So suicidal RV is a very dangerous thing, and we should be aware when you are doing slightly adolescent pulmonary valve dilatations, and it's very dangerous. All right. Okay, so this is just the subcostal view where you can see very nicely your color Doppler probe probably can be aligned very nicely to check the post-op gradient. This you can really zoom on the valve and then check the gradients. Always, this view is also very good to check the amount of pulmonary regurgitation which has happened. And see, this only mild pulmonary regurgitation which has happened in this particular child, which is again very acceptable. Okay, balloon atrial septostomy. What are the things which we should assess after following the BAS? So gradient and flow across the PFO, gradient across the mitral valve is very important. If the septostomy was indicated to relieve pulmonary venous congestion secondary to mitral stenosis. So if you have a subset like that where you are doing balloon atrial septostomy, relieve the left atrial pressure, and then the gradient across mitral valve is a very good indication how well you have done the balloon atrial septostomy. And the saturation should improve at least 20% from what it was existing prior to the procedure. Okay, that is a very nice tear of the septum and very good unrestricted flow across the balloon, across the atrial septum. And the PFO gradient is again very important. It gives a lot of indications like what is the LA pressure, what is the LV, EDP, everything. It gives a lot of information. Okay, transcatheter closure of ruptured aneurysm of sinus of valsalva. We should look for, before I go on to the post-interventional assessment of these cases, people should be very clear about which ruptured sinus of valsalva should be closed and which should not. Patients who have like VSD, ventricular septal defect, or patients who have aortic regurgitation, significant amount, they should not be closed in the cath lab. They should be straight away sent to the surgeons. But there is a big set of RSOVs which doesn't have VSDs with intact IVS and hardly any aortic regurgitation. Those are the patients who are very suitable for closing with the device. So residual shunts should be always looked after, because these are again very high pressure residual shunts. So these have a high incidence of hemolysis. Location of the device is also very important, and it should be made sure that they are away from the coronaries. Aortic regurgitation should be, because you are putting some foreign material in the aortic sinus. So whether there is any change in the geometry of the aortic sinus and that causing AR, that should be clearly looked into. Cardiac chamber sizes, this is something really fantastic which happens. Like we have seen heart X-ray full of the heart, the chest full of the heart, and that reduces to normal sized heart in just 2 weeks time. So that is very important to note and know the result of the procedure. Cardiac function, like a lot of patients present with severe ventricular dysfunction, and these ruptured sinus of valsalva patients are very, very sick. These are the devices. Okay. Now another last procedure, ductal dependent circulation. It can be either pulmonary or systemic. Flow across the ductus, stent, stenosis, collapse. This we should very carefully look into, because these are very small stents. Like this will be usually 4 millimeters, 4.5 millimeters, 3.5 millimeters stents. So these patients should be put on proper antiplatelets and anticoagulants, and they should be on every checkup. And these patients should be very closely monitored till they get on to the second stage palliation, that is the Glenn shunt. Till then they have to very on close follow up what is going on with the stent flow. And flow in the branch pulmonary arteries, whether it is adequate or not. And pulmonary venous return gives you a very good indication whether this flow is going enough into the pulmonary circulation. Branch pulmonary artery size to assess the suitability of the next stage of surgery, which is usually the Glenn operation. Ventricular function. Aortic valve regurgitation is also important, because significant valve regurgitation becomes again a core subset for the Glenn operation. This is a PDA stent, ductal stent nicely, and we can see very good flow into the branch pulmonary arteries, and also very good amount of pulmonary venous return. Okay, this is just a pretty picture of the stent, and thank you. Okay, I don't want to go to that. Okay, I will just 6 years old lady, yeah, 40 years old lady. Very interesting story to this. I think this is a nice story to end the day. She was diagnosed to have ruptured sinus of valsalva in the year 2008, and then we are advised her urgent admission, but somehow she fled the hospital. And more amazingly, she got pregnant and had a childbirth, and after the childbirth she decompensated. So all these 3.5 years she was just living with the ruptured sinus of valsalva. It is amazing, incredible India. So we got her this time luckily alive, and we could close the ruptured sinus of valsalva very nicely. So this is what you see. This is a pictorial catheter into the. Sorry, okay. So I'll just stop it at the right moment. Yeah. Okay. So this is the non-coronary cusp flowing into the right atrium. So this was the non-coronary cusp rupturing into the right atrium above the tricuspid valve, just above the tricuspid valve. Now you will appreciate when I play it. Nice. Yeah. See, this is the flow into the floor of the right atrium. So the procedure is also again like we do an arteriovenous loop, and finally we put a PDA duct occluder. The windsock measured, the neck measured around 8 millimeters. So we put a and when we did the angio and measured it, it was measuring around 8 to 10 millimeters, and since the defect was very quite away from the coronaries, that is another thing we have to check. So we put 14 by 12 duct occluder, and the result was excellent actually. So this was the releasing of the device, and then post device angio, which shows a little bit of intra-device leaks which settle off by evening. Yeah, that was that was the case.